Okay, discussion 3.2, bipolar disorder. Um, excuse me. Okay, so the various counseling techniques provide multiple advantages as an adjunct for those with bipolar disorder. The main three therapies that have received empirical evidence to support its success as an adjunct to medication are interpersonal and social rhythm therapy, or ISRT, cognitive behavior therapy, CBT, and family focused therapy. Um, the monitoring aspects of the ISRT can be used to help the client become aware of their triggers and precipitants. So, with this information, they'd be able to predict what might trigger a future episode and take that proper step or the proper steps needed to avoid it. Cognitive behavior therapy, on the other hand, can help improve many of the symptoms of bipolar disorder, including the stress and the negative thoughts. It can also be used to improve adherence to medication with the use of things like behavior contracts and cognitive techniques. It can be used to help the client monitor moods and cognitions, help challenge faulty beliefs and thoughts, and replace the faulty beliefs with healthier ways of thinking. Clients can improve interpersonal communication, develop a gratitude checklist, or use activity sheets to schedule pleasurable activities. Families focused therapy, on the other hand, can help family members learn to communicate effectively to a client without being critical or emotional. For the client, they learn to understand their disorder better and understand the genetic components of it, or the biological components of the bipolar disorder. In counseling, I believe the primary purpose is skills building, and obviously with bipolar disorder, it's also for managing mood swings, managing those symptoms, and of course managing medication. Counseling is a sole treatment for bipolar disorder. I don't think it's recommended, mostly because I think that it might be, um, um, what am I trying to say? I don't know. It may be worth exploring, but I do know that even with worth exploring, if medication alone is not recommended. So I don't know if either one of them alone is recommended. To me, in my opinion, it needs to be a combination of both counseling and medication. Seems to be the most beneficial in when treating individuals with bipolar disorder. Obviously, there are people who might not be able to take medication for bipolar disorder for various reasons. Either, it could be somebody that's pregnant or breastfeeding or a child, or elderly person with too many medical conditions, anything like that. So, for these individuals, all they really have to do is all they really have is to uh, have as a form of treatment is to have counseling as a technique. So, as a firm believer of the whole, try to avoid medications as much as possible. I believe that for individuals with bipolar, though, the medication is needed to even get them to the point where they could benefit from counseling. Um, in this instance, the biological aspects of the bipolar disorder make it almost impossible to get any help without first addressing those biological conditions. When it comes to the features of bipolar disorder being mistaken for schizophrenia, basically, it's the psychosis that is often mistaken for schizophrenia. Psychotic features such as the hallucinations and delusions can occur during a manic episode or depressive episode, and could look a lot like schizophrenia if you aren't looking for those other symptoms of bipolar one. Um, Regarding um, likes and dislikes about working with someone with that was in a depressed state or a manic state, um, hmm, uh, I was very surprised to see how different Barbara in that video, how she acted in the second part of the video from the beginning, from the first part. In the first part, she seemed very depressed and quite frankly out of it, almost like she was just like all drugged up, just very just sedated almost. In the second part, she was super manic, just off the roof, as if she was on some kind of, I don't know, uppers or whatever, um, some kind of drugs that's causing her to be extra hyper or something like that. So, um, she got to the point that she was actually sort of borderline inappropriate in her actions and her responses to the therapist. And I think one of the most challenging things about working with these individuals would be not knowing which person you were going to be sitting in front of any given day. Are they going to be in some other disorders? You kind of know the person, you find out about the person at the beginning, and they're pretty much going to be that person throughout. But when it comes to the bipolar, you don't know which personality is going to be presented in front of you for that given day, and depending on who they are for that day changes how you might approach them. Changes how you might treat them for that day. So anyway, so that I feel like is the most challenging part about working with individuals who have bipolar disorder or psychotic episodes. The constant ups and downs seem like this could be exhausting to both the client and the clinician. It takes a certain type of person to work with individuals with a bipolar disorder diagnosis. Someone with an above average amount of patience and don't take things personally, I would think. And I'm sure, well, no, I'm not too sure if I'm that type of person. I do have patience. I don't try not to take things personally, but I don't know if I have it enough in me or even feel the desire to have it challenged to see if I have enough in me for working with the individual with psychotic episodes like those in bipolar disorder. Anyway, so that is discussion 3.2, bipolar disorders. Thanks. Till next time.